Okay, let me set record. Plan for today is to cover the cognitive disorders. And I will try to give you a feel for what this looks like. Okay, can y'all see the PowerPoint? Cool. All right. Okay, so let's define the cognitive disorders. These used to be called organic disorders. And the term organic, we're not talking about foods that are grown without pesticides, that kind of thing, but organic in terms of biological. Okay, so these are going to be the disorders that are more of a function of brain injury or brain disease. Okay, and so these are going to be brain dysfunction from any of these causes. It could be trauma to the brain. It could be disease to the brain, so something like Korsakoff's or Alzheimer's. It could be nutritional if somebody is malnourished enough and not getting adequate nutrition to the brain. It could be disorders related to too low, too high neurotransmitter substances. So an example of that might be Parkinson's disease. And it could be brain damage because of substance abuse. And in particular, one of the substance abuses that we see causing brain damage is people with alcohol addiction. This kind of gets them in a double whammy because people with alcohol addiction tend to drink instead of eat, and they tend not to eat very well. Added to that, alcohol interferes with vitamin B absorption. Oh, and I realize I don't have my video on. There we go. Okay, here I am. So interfering with vitamin B absorption and malnutrition is going to create this thing called Korsakoff syndrome, which is a dementia that can be brought on by alcoholism. It can be, these cognitive disorders can be either temporary or they can be permanent. And there is either a presumed or a known biological cause. And this is only diagnosable if it affects daily functioning or creates enough suffering and then problematic functioning. Okay. Okay. And the ways that we assess for these cognitive disorders, there are certainly medical scans that can be done if there are really dramatic kinds of abnormalities in the brain that these scans can see. So a CAT scan, an MRI, or a functional MRI. These two are going to look at structural issues in the brain. A PET scan is going to look at where electrical activity is happening in the brain. And normally when a person is underneath a PET scan, you have them doing a variety of different tasks that are meant to light up the electrical use in areas of the brain to see that. But the most sensitive way of determining cognitive disorders is what is called neuropsychological testing. And neuropsychologists are clinical psychologists like me, but they have specialized in training in neuropsych. I did 1 3-month neuropsych rotation, and it was enough for me on my internship to gain an appreciation for neuropsych testing, but this is by no means my area of specialization, and I do zero testing nowadays. But I'll give you a little bit of a feel for what this neuropsych testing looks like. With this, we're trying to assess brain function. And the testing is meant to start looking at global function of the brain at first. And then if there are any deficits or any problems, then the neuropsych testing gets more into areas of the brain and different functions of the brain to really try to pinpoint what's going wrong, where it's going wrong in the brain. And as well as doing neuropsych testing can give us baseline data that then might be used over time as we track somebody who's struggling with a cognitive disorder. I'm hearing somebody talking and it doesn't sound like asking a question. So if everybody can check on their mute, but if you've got a question, feel free to unmute and ask your question. So for this neuropsych testing, we make sure when we take this test and the test outcomes and the test data that we are comparing this data to individuals of a similar age It would not be fair to compare a 65-year-old to a 20-year-old as an example. We make sure we're comparing this to that individual's sex. So we're comparing women to women, men to men. And we're looking at normative data. So we're looking to see if we know sort of what the mean is for that person's sex and that person's age. And we're looking to see if on that normal bell curve, does this particular individual have deficits, or do they have significantly lower ability to function on whatever that test is measuring? Okay. And the nice thing about this is it can detect really mild dysfunction. So even as sensitive as mild dysfunction, an example might be a learning disability or pretty mild ADHD, it's going to be able to detect that. Whereas when you use these scans on somebody with ADHD, and you're probably not going to see it as an example. But when you look at how the brain actually functions or performs, then if there is any mild dysfunction there or major dysfunction, you're going to see it. And again, sometimes we do this to get a baseline, and then we will retest over time to get an idea of, is the cognitive dysfunction progressing rapidly? Is it moving along really slowly? Sometimes we use the retesting to determine if a treatment or a medication is helping to slow the progression of the disease. So any questions there about how we assess this stuff? Let me give you an example. This is not an actual psychological test, but I have mimicked one. And this test that I am mimicking here is called Trails A, B, and C. And the Trails piece to it is you've got the particular client first taking this test, and they're timed, and they simply take their pencil and they start with A and they do their ABCs. Okay. And this is going to sound really easy to you all as nice, healthy college students. But they would do it as fast as they could. So they would do A, B, C, D, E, you got it, F. And you would time it and see how quickly they were able to complete. That's Trails A. Okay. So basically, you've got this person saying their ABCs and then mapping it out in a trail on the test. And then the quicker they can do it, the better their brain functioning is. The slower they do it, the worse the brain functioning. And then we also, in the scoring of it, we look at not only how quick the time is, but we look at how many errors they've made. Then we do Trails. So this is Trails A. Then we do Trails B. And here you're simply doing exactly the same thing, but you're counting. So you would have the person go 1, 2, 3, 4, and you would time it, same kind of thing. The challenging part is the Trails C, because here you've got a person counting and saying ABCs and alternating. And so it would be 1A, I'm not seeing 2B. I'm not seeing 3 on here. It might be behind where I'm seeing my students here. And you would have them go, and what they have to do here is they are counting and they are saying their ABCs, but they're having to shift back and forth. And if you've got people with some cognitive dysfunction, you're going to see not only a very slow test here, but you're going to see lots of errors. Okay. And I think even you college students can kind of appreciate, you all would do really well with something like this, but I think you can appreciate that, say, somebody who is elderly, somebody who had a head injury would really struggle shifting back and forth with the counting and the ABCs. So does that give you a little bit of a feel? This is just one example of one cognitive test, but does it give you all a little bit of a feel for it? Okay. If you can show if you've got the bandwidth, if you all can show your picture, your wonderful faces, so I can see some faces in the crowd, that'd be great. Okay, delirium. So when we think about the word delirium, there was a wonderful Prince song, Once Upon a Time, delirious, I get delirious. When we think about delirium, we usually think about people kind of acting crazy and having fun. But actually the word delirium here means straying from the line. And here what we have is there's some kind of disturbance in attention in the person's ability to direct their attention, focus their attention, sustain their attention, and shift their attention. So somebody in delirium, if they were doing trails A, B, and C, they would have difficulty on C, shifting back and forth, or they could even start taking the test and then just quit. Like that would be problems in sustaining attention, as an example. So disturbance in attention and awareness and reduced orientation to the environment. So not tuned into reality, sometimes way tuned into all kinds of activity that's going on internally in their brain. And then there has to be a disturbance in cognition. So either memory deficits, of like one of the questions we would ask when we would round on people in the hospital is, what'd you have for breakfast? What'd you have for dinner last night? When is the last time a family member visited you? And a lot of times we see disorientation. And so the way that we ask if people are oriented, we ask them, what's your name? Do you know who you are? Do you know where you are? And do you know the date and the approximate time of day or night? Okay. And in that situation, if people know that, they know who they are, where they are, and the date and time, then they are considered oriented times 3. Okay. So athletic trainers, as an example, you get a football player, it goes down. Let's say they got hit pretty hard and you suspect a concussion. That trainer's out there asking them those questions. Do you know who you are? Do you know where you are? Do you know what day and time it is? Do you know what team you're playing? And see if they are able of answering that. Okay. Now with delirium, this develops very quickly. It can come on very quickly. It reflects a dramatic difference from baseline. And it can fluctuate in severity. So like these people can kind of come in and out of the delirium, or they can go into a deep delirium and stay there for a long time. And they say here these symptoms are not better explained by an established medical disorder, but again, there usually is a presumed medical disorder driving this. But then they warn us, if they are withdrawing from a substance that they've been using on a regular basis, or they have consumed some kind of toxic substance, then we will take that into account here also. Okay. Any questions here? Because I'm going to exit the share screen and I want to show you what is happening to some of these poor folks right now with COVID delirium. Shoot, that's not what I want. Okay. Let me get my clip here. Y'all hang on for a second. Okay, I found it. Yay. Yay me. Okay, can you all see this screen? Okay.
I remember very clearly a nurse speaking very loudly, wanting me to kind of understand, Josh, you came to the emergency room, you are in the ICU, you tested positive for COVID, you have a breathing tube in, you need to relax and breathe or you are going to die.
I was like having these hallucinations where I would like be passing out and really slowly be falling at a super slow rate. I remember having thoughts like, oh, I'm dying and this is gonna hurt when I hit my face on the ground.
I thought one of the nurses had taken a circular saw and just buzzed my arm off, and then just buzzed off both of my legs. Another circular saw came through the wall and just cut my head in half. I was positive they were trying to kill me.
Hey, baby girl.
Hey.
My oxygen levels dropped. My lungs were filling with fluid. I had ARDS, acute respiratory distress syndrome. They gave me the COVID-19 coronavirus test. It came back positive, and I was told I would have to be put on a ventilator. As they were getting me ready, I was just praying the Hail Mary over and over again. I was just thinking about my 2-year-old son. I want to see him graduate college. I want to see him maybe get married or have kids. I want to see him grow up. I don't want to die.
They didn't give my wife much hope at all. About the second day in, I was ready to write a note to the nurses to just kind of take me off life support. I had a lot of confusion going on, wasn't sure how I'd gotten to where I was. I had actually developed ICU delirium.
We used to think we're doing these patients a favor by keeping them completely sedated and in a medically induced coma so that they wouldn't have any memory of this difficult time. But that kind of backfired because unfortunately, they often do have memories, but they're false memories. They took real life stimulus and turned them into something really, really scary.
The hallucinations were just unbelievable and so real. They're not nightmares, they're memories.
Even when you're sedated, it's not like you're asleep. There is a level of consciousness.
The muted, sort of restful, peaceful look that some folks can mistaken for they're resting, they're sleeping, when in fact their brain is on fire.
Their brain, globally, what's happening, the cells aren't working right. They're not getting enough oxygen or blood pressure or food, for example, and those cells start to go awry.
So you can imagine you get critically ill, you didn't plan it, so you just wake up in a medication-induced haze. You've got a tube down your throat, your wrist may be tied, there's nobody around you that you know.
Under any other conditions, that would be considered torture. These 2 women hold my arms down while they shoved a tube up my nose was extremely traumatic. I still have such vivid memories of that. I couldn't move my arms very well until that started happening to me, and then I was flailing.
Patients would have these vivid nightmare-like experiences of people torturing them and kidnapping them. They saw blood dripping down the walls and seeing people with animal heads walking around, or children who are floating by with no faces.
We had a young patient, and he thought the nurses were restraining his arms and attaching snakes to his arms, and that was then drawing blood from him.
We've had patients who are taken from the unit to get an MRI. They're convinced that they're being moved into an oven.
B&H, how can I help you? B&H is here, from our homes to yours, as your collaborators create.
They may have a catheter that is removed. They're very convinced, under the influence of delirium, that someone has tried to sexually assault them. That delusional memory is quite traumatizing.
Even when the patients recover and they know that these things didn't happen, the terror is still so real.
I go home and nobody said anything to me about the hallucinations that I would have once I withdraw from all those drugs. This doesn't end when you walk out the door of the hospital.
Our patients often say when they follow up with us, I was in the ICU. I don't think anything happened to my brain. It was a problem with my lungs. I think I'm going crazy.
ICU was, of course, extremely difficult, but the delirium was the hardest. When he had came home that day, when I first got to actually talk to him after 8 days, it was just like this huge relief, like, oh, we made it, everything's gonna be fine. I wasn't thinking, oh, he's gonna have delirium. That night I walked in the bathroom and he was just sitting in there, and he was counting on his fingers, and I kept asking like orienting questions, like, where are you? Like, what state are we in? And he couldn't answer any of them. I was talking to his home health nurse. I was like, do we need to get on an antipsychotic? The ER doctor called and said, he's fine. This is delirium.
I was having constant breakdowns, meltdowns, anxiety attacks. There was absolutely no mental health follow-up at all.
This frequency may be close to somebody that actually was in combat or somebody that was sexually assaulted. So it's incredibly common.
The first day out, sweating and stuff. Then I went into a panic attack. It's like this, I'm in a room by myself, you know, and everything started to fall, coming down on me at once.
After I got out of the hospital, I began to experience major depression and post-traumatic stress symptoms. And they surprised me so much because I thought I was through it. And then I just kept having all these nightmares where I was like fighting to wake up, fighting to wake up, fighting to wake up. I just reached a point where I wished I had died.
If you have somebody who gets out of the hospital from COVID, all communities need to have their mental health people ready to rock and roll. They're going to be pushed home with no support. And because their loved ones didn't watch them go through this, they don't know.
Emotionally, you're by yourself. I was alone for 4 weeks, 5 weeks, 6 weeks, without my kids, without my support system. You're in your head, you're almost dying. How do you get over that and get back out into the world and act like nothing happened?
If you had to design an experiment to make delirium as bad as it could be, COVID is it. Not only do you have more drugs, a longer illness, but now you have absence of family and absence of mobility, which are two of the main things that reduce delirium. So we really have a worry that we're going to have this massive public health problem. COVID is essentially a delirium factory.
Delirium seems to be one of the biggest risk factors for future long-term issues. Half of the folks end up being unemployed if they were working previously, and many of their lives end up getting upended. Folks get divorced, they have the inability to run their finances, and that's pretty devastating.
We're going to have such an unprecedented cohort of ICU survivors. Surviving and getting a life back are two different things.
We have kind of this perception that people are sick and then they bounce back. But that's not the way it is at all. It's this chapter of your life happens and it changes every chapter after that. Being a COVID survivor is you're our beacon of hope right now. I see those lines of people leaving hospitals and the staff is applauding. When COVID isn't in the news every day and people aren't applauding the COVID survivors, I think you're going to see people who live really, really difficult, painful lives as survivors.
Thoughts, responses? That's scary, isn't it? It's terrifying when you think about how some of these individuals are being harmed, particularly the ones with the acute respiratory distress syndrome who've had to be on ventilators. So when we hear about, again, like she kind of said, when you hear about somebody who had to go to ICU, had to be put on a ventilator, and they do survive, physically they survive, we consider that a victory. But there's, for a lot of these individuals, a lot more going on than pure victory with this kind of stuff. Any comments or questions?
I just had no idea like the extent of the delirium. I didn't even know that it was like prevalent after being on a ventilator, after being hospitalized. I had no idea. So that it was kind of a shock to me that these patients are experiencing that after recovering. Like, that's scary. And I had no idea that was a thing.
And my thought on that is you all get the word out. You know, like for people, again, if they've got family members that are coming back home or you've got friends, be on the lookout for these kind of symptoms, because it sounds like the way they're describing it, that these nightmares that are occurring during delirium feel like they are real memories, like these things really were happening, as opposed to for us normally when we wake up from a nightmare, or, you know, like we said when we did sleep disorders, like, oh, that was a nightmare, that didn't really happen. For these individuals, it feels very real. And what I'm very concerned about is that we're probably going to see spikes in suicide for individuals who they don't get their physical health back, they don't get their mental health back after these kind of occasions. So we really do, like that woman said, we really do need to be vigilant about potential mental health issues spinning out for our survivors. Okay. So we're going to move from delirium to dementia now. And the key defining symptom for delirium, straying from the line, is that it usually fluctuated, but would oftentimes go away. But again, with what we're seeing, we don't quite know. We have not studied it well enough with these COVID victims. Does it go away eventually, or does it kind of ebb and flow, like the woman was talking about her husband in the bathroom, and that he was totally out of it, even though he was off a ventilator and had sort of become clear, but then kind of had a relapse of the delirium. Dementia, let's talk about major neurocognitive disorders. So now we're talking about more like Alzheimer's disease. So I think you all have some familiarity with that. But let's talk about what this looks like. Here we've got evidence of significant cognitive decline from a previous level. And either the individual's concerned or a known informant, like a family member, a partner, a friend, a roommate, is reporting significant decline. And then there's impairment in cognitive performance. And preferably that has been documented by standardized neuropsych testing, like we were talking about before, or clinical assessment. So usually the diagnosis of this is made with in-depth interview with family, friends, somebody who knows the individual, testing of the individual, and then maybe some of the scans or other types of clinical assessments. And these deficits, these cognitive deficits are going to interfere with independent functioning in everyday activities. And they clarify here, this isn't occurring exclusively during a delirium. So if you've got this dementia and you've got this steady decline, that diagnosis trumps the delirium diagnosis. Okay. Mild neurocognitive disorder is when there's evidence of modest cognitive decline from a previous level. And again, the information is found out exactly the same way. But at this point in time, there are some deficits there, but they're not severe enough to be interfering with independence in everyday activities. So a person with mild cognitive impairment can usually live outside of a nursing home, as an example, as long as there is either home health care, like a CNA, a nurse visiting them, or there is a family member or family members who are able to assist them around the clock. Okay. So many of these individuals are still living in their homes at the mild level. And the causes of dementia, many times it is Alzheimer's disease. So Alzheimer's disease would be what's going on organically, biologically in the brain. The dementia that we would be seeing would be the brain's performance deficits and the problems that individuals are having in their ability to keep up with those activities of daily living. Okay. Others, Pick's disease, which I don't know much about. Korsakoff's, we've talked about, from chronic alcoholism. There could be tumors that have developed in the brain, and they could be either benign, which is non-cancerous, or they could be cancerous tumors that are proliferating in the brain. And as they proliferate, they are putting pressure on different areas of the brain and creating dysfunction. There can be metabolic imbalances. And so usually doctors will run lots of blood work when any of these things are suspected, also looking for thyroid imbalances, liver, kidney imbalances, to see if there's anything metabolically going on that could be corrected with medication or potentially surgeries. There are vascular dementias, and vascular dementias would be because of blood flow issues. And there are two types of vascular things that can happen that are called cerebrovascular accidents. And there are two types of cerebrovascular accidents. The lay term for that is stroke. So there are two kinds of stroke. Okay. The most common form of stroke is when blood vessels that feed the brain become so clogged up from atherosclerosis, which is going to be a function of genetics, diet, and lack of exercise. When major blood vessels like carotid arteries clog up, then there are major portions of the brain that are going to be deprived of oxygen, and the brain tissue dies very quickly when there's lack of oxygen or hypoxia. So the most common form of stroke is that ischemic stroke because of those clogged arteries. Okay. The less common form of stroke is called a hemorrhagic stroke. And a hemorrhagic stroke is when you get a bleed in the brain. Okay. And the bleed could happen because of substance use. The bleed, oftentimes the most common cause is some kind of head injury. Okay. So like a person who was in the field and got hit with an IED as a soldier, getting hit and creating a bleed inside the brain that if it's not stopped very quickly, that person's going to die. So my father years ago, and I actually witnessed his bike accident, he rounded a very, very sharp downhill turn, hit gravel, and he swayed a bit, and then he smacked down on his helmet. And what happened for him is he hit in one area of the brain, and where his brain bounced on the other side of the brain, it created a bleed. And he was choppered and got emergency intensive care, and they put a burr hole in, tried to relieve pressure in his brain because the bleed was creating more and more pressure. And if you don't relieve the pressure in the brain, you got a lot big issues going on. It's kind of like if you've ever had a bruise under your fingernail beds or your toenail beds, and it hurts like crazy because the swelling's got nowhere to go, and you have to poke a hole in it and relieve the swelling. Or a burr hole is where they will burr a hole in the brain through the skull, trying to release some of that inflammation and some of that pressure. For my father, thank goodness, the area of the brain that where he had that hematoma and he had that bleed, his bleed was not nearly as big as this picture here. It is a tiny bleed. They had to actually go in and surgically remove that hematoma. And thank goodness it wasn't a really critical part of the brain. But once they relieved that hematoma, his whole brain stopped reacting to the injury. So the swelling eventually came down, and he was able to do rehab and get most of his functioning back. He doesn't have mental maps anymore. He thinks he does, but he doesn't. He thinks he knows where he's going when he's driving, but he doesn't. And it's funny and not funny to be in the vehicle with him. Okay, so those are the vascular dementias. HIV, we have done such a good job in the last 30 years of being able to detect HIV before it becomes AIDS. And if individuals have access to healthcare, getting good medication to keep AIDS from HIV from converting into AIDS. But AIDS will cause, if it's gone untreated and it's gotten severe, AIDS will cause dementia. And the really sad thing about that, years ago when we saw a lot of patients who had that, is they were oftentimes young, and they would go into the dementia and then kind of come out of the dementia and realize how badly things were getting, even when they were a younger person, as opposed to somebody who is much older. And then the head trauma that we've kind of talked about here a bit. A concussion is when the brain bounces and has some inflammation. A contusion is when the brain bounces and starts bleeding. So that's kind of what happened to my father. He hit on one place and the bleed started where it had bounced. And then a full-blown laceration. Many of you remember hearing about Phineas Gage in your intro psych class, where he got blown through his skull a railroad spike. And he lived through it, but he had these dramatic personality changes after something had actually intruded in through his brain. So any questions here on these different causes?
I have a question.
Okay.
And you might have answered it, and I could have just missed it, but what exactly is the difference between dementia and delirium? Is dementia just it lasts longer?
There, there's an overlap, and I think with the COVID kind of thing, we're sort of realizing, like, is this clearly just delirium, or is it delirium that grows into dementia? Right. But you're right. The dementia tends to be, so if we did a graph, the delirium, you would see fluctuations. And with the dementia, you just see continuous decline. It could be rapid decline, or it could be like a step function kind of decline, but it keeps declining. Yeah. Does that help, Kendra?
Yeah, thank you.
Okay. And again, I don't want to speak too much about the COVID because we haven't studied that enough. We just don't quite know. Are these people who've had the COVID delirium going to have earlier onset dementia than, say, they would have without having contracted the virus? More science to come, hopefully. Okay. So 50% of dementia cases are Alzheimer's driven. And so a lot of times lay people refer to Alzheimer's disease, but keep in mind the psychological diagnosis would be the dementia addition to the Alzheimer's dementia. So half of all cases, and then I've got another clip that I want to show you. So let me stop my share. There we are. Okay, let me share my screen. And here we go. I want you to know about the Alzheimer's Association and some of what they do, especially if you have any family members who...
This is not a joke. This is a serious problem. It's not a rare disease. It's a common disease, and it's going to become increasingly common as the population ages. And while most of the other chronic diseases are going down in frequency, this really stands out as one of the two that's growing very, very rapidly.
There's 4 million people with Alzheimer's today in this country. In 20 years, it'll be at least double that. And our company, like many companies, is full of a generation of baby boomers who are facing this challenge.
People are under the impression you have to be a senior to get Alzheimer's. And they don't understand Alzheimer's. They don't understand dementia. They just think it's a little forgetfulness, maybe you should eat better, it's just a lack of education.
The most common question I get asked is, does my mother have dementia or Alzheimer's disease? So part of my task is education. Dementia is a general term, and Alzheimer's disease is a specific disease that is a dementia. The first major sign of Alzheimer's disease is memory loss. The second is difficulty performing task, familiar task. A third is often a language disturbance, misusing words. Fourth, disorientation to time and place. Fifth, problems with judgment and reasoning. Another is difficulties with abstractions or concept thinking. Another is misplacing objects. There may be a change in personality. Some people have a change in mood. And finally, there's often a loss of initiative.
When I took care of my aunt, and I read one of the magazines, she already had 7 of the 10 warning signs. And immediately I took him to the doctor. That's what I tell people. If you notice something is not right, take him to the doctor to find out, what the problem is. I didn't even know I was a caregiver until I came to the association because I already took care of my mom.
I am like a stay-at-home mom. I take my mom to school, then I have a few hours free, then I pick my mom up from school, then I have my mom to take care of, and that's my job. That's what I do full time.
The hardest thing to do is to engage a caregiver to take care of himself or herself. It's absolutely the hardest part of this process.
The first year that Charles is ill, I got very sick, very, very sick, just from taking care of him and taking care of Lindsay. And
And again, I actually took some time off. I had to call my mom to come and stay with us because I was so sick. And even at that, there was so much guilt. You don't understand until you've lived it. Everything has changed.
I basically help my mom take care of my dad. I've been doing it since I was about 8 years old. I help him get dressed, I cook him meals, and I turn on the TV, put his seatbelt on. I want you to hold on to the walker, be very careful, okay?
My life revolves around my mother. I think about her 24 hours a day, 7 days a week, even if I'm not with her. When I was told that I had to quit work, that was probably one of the hardest days for me. That was my life, that was my freedom, and for me to stay home for something I didn't know about. I knew nothing about this disease. I didn't know what I could do.
It's a human cost to some extent, and people being out of work, missing work to provide care. I can't tell you how many times I flew across the country to spend time with my dad.
It really is a labor of love. It's exhausting emotionally and physically, and very often the person who's the caregiver ends up being a patient as well because of the demands that are made on them.
It's very important that people begin to get out there and look in their community and ask questions. Long gone are the days where family members do it all by themselves.
First and foremost, there's the Alzheimer's Association. And let me speak in broad terms. The Alzheimer's Association just has a vast array of knowledge as well as people. And even on the brochures, there's a 24-hour hotline. I checked it out. It works. So the Alzheimer's Association should be at the foundation.
We were able to recognize the large Spanish-speaking population and start a program that would help them. From that, we went into the Asian Pacific Islander, we went to the African American communities, and all of these things happened because people began to know what Alzheimer's is. When we
Okay, so I wanted you all to know about that organization, and particularly if you've got any of this kind of going on with family or friends, make sure that caretakers reach out and find what resources are available. Ooh, what did I just do? What resources are available to them, either nationally or locally in their communities. Okay, let me get my share back on here. Okay, so we've got about 10% of people over the age of 65 will have some Alzheimer's disease. And in many of these individuals, about a third of them will develop psychotic symptoms. And so some of what you heard in the COVID hallucinations, the nightmares that people were having, that would be considered psychoses. Okay, so in that delirium, they were having psychotic symptoms. And I want to tell you a little bit about this woman that I saw when I was doing a neuropsych rotation, and we were trying to figure out what was going on with her. And I go into her hospital room, and she's an elderly woman. She's with her elderly husband. And I spend some time getting a case history from him because I've heard she's not going to be a reliable historian of herself. So I get my history from him, and then I ask him, like, Mr. Smith, can you please go out in the waiting area while I interview your wife and I do my testing for her? And the reason why we do that, you don't have family members around when you're doing the testing, because the family members will oftentimes try to kind of help people with the tests, and they kind of cheat for them, that type of thing, out of kindness. And so you always do the testing alone. So I ask him to leave, and then she becomes somebody that I don't think she was. And I'll tell you, we're adults here. I'm going to use the language that she used. Okay. So I'm like, Mr. So-and-so, can you please go out into the waiting room while I interview and test your wife? And she starts yelling. She goes, you son of a bitch, you better get out of here before I blow your goddamn head off. And it's like, whoa. And the poor little fella, he's just kind of walking out, of the hospital room. And I just had a great sense of empathy, because this is the woman that he loved. And this is how sick she had become. And this is how mean she had become. And later on, after she yells at him, and I'm attempting to do testing, which does not go well at all, she jumps up on her hospital bed and she's up there and she's watching the floor and she's like, the blood, it's in a river. Like she's seeing a river of blood flow through the hospital room, which is why she's up on the bed trying to stay out of the blood. Okay. So you get a feel for this, how haunting this is for patients who have these psychotic symptoms, and how incredibly stressful and haunting this could be for family members who are trying to caregive. And particularly in his situation, because she was just so mean. And he was not deserving, and this was just a whole different person that he saw. When we do autopsies, there's really no like organic test that you do for Alzheimer's when the person is alive, but a lot of times individuals ask for autopsies upon death. And you can see what's going wrong in the brain. There are these plaques that build up, and there are these neurofibrillary tangles that build up. So what you're seeing is brain tissue that's normally nice and jello-y like, okay, floating around in cerebrospinal fluid in our skull, becomes hardened. So tissue becomes hardened. And then you get what would be normal, neurons are getting all tangled up. And so it's no wonder that there's tremendous amount of confusion or psychoses and cognitive decline in these individuals. The nun study, I do want to mention the nun study, and I thought that was kind of fascinating how some researchers get really creative. Most nuns who join like in their teen years or their early 20s join and become a nun, they don't use drugs, they don't drink alcohol, they usually have very healthy nutrition, because a lot of times they run their own farms, they run their own gardens, they tend to eat rather organically. The research on the nuns, there are a bunch of nuns who've donated their brains to science upon their death, and it's one of the few places in research where we've been able to study really clean brains, if that makes sense. Because most ordinary people who end up developing Alzheimer's or die with a great brain health have not eaten healthfully, have drank alcohol, used other substances, smoked cigarettes, that kind of thing. And so it's been some really fascinating research. What we used to think, and again, neuropsych is not my area of specialty, so I'm doing the best I can here to kind of give you the old way of thinking in a new way. Early on, the scientists thought that Alzheimer's was this genetic thing, and there is genetic risk, okay? But the thought was if you had the genetic risk, that would determine you're going to get Alzheimer's disease, okay? And you're usually going to get it at the age that, say, your family members got it. Nowadays, we know it is clearly nature nurture. It's genetics interacting with environment and behavior. Okay. And we know that individuals who eat healthfully, particularly low in animal products, have less Alzheimer's disease. People who exercise on a regular basis. And I just think this is real simple, y'all. When you exercise, your brain gets extra nutrition and extra oxygen, extra blood flow, extra oxygen, and a well-oxygenated brain is a healthy brain. A person who smokes cigarettes gets very poor oxygen to their brain, as an example. And somebody who stays seated or laying down day and night, who's sedentary, gets very poor circulation and oxygen to their brain. Okay. So now we know that there is a lot of lifestyle components, and I teach this stuff in my health psychology class. If y'all want to hear more of this kind of stuff, consider the health psych class either from me or Jackie Wayne. But there's genetics interacting with lifestyle. Okay. So the healthier we are physically, the healthier we're going to be mentally, and the healthier we're going to be cognitively in later life. If we follow an unhealthy lifestyle and we have genetic risk, we're a lot more likely to suffer physically, suffer mentally, and suffer cognitively and develop Alzheimer's. So there is something that can be done for prevention. So let's talk about these, the different kinds of level and the diagnostic criteria. We consider it to be early onset if it happens before the age of 65. Late onset is the most common, and that would be onset after the age of 65. And by 85, the risk is 50-50. So this is definitely something that we see more of with age. And that could be natural aging, but then another way of thinking about it, when I think about the lifestyle components to this kind of stuff, if you've had a poor lifestyle, the longer you've had the poor lifestyle, the longer it has had time to catch up to brain health. Okay. So as the baby boomer generation ages, so that would be my parents, that is probably your grandparents or your great grandparents are in the baby boomers. We expect to see a doubling of Alzheimer's between the year 2000 and the year 2040. So and keep in mind, the baby boomers are this big bubble of people that were created out of rapid reproduction following the world wars in the United States. So after the wars, there were a lot of babies made in celebration that the wars were over, and a lot of babies made to help work the farms and the family businesses that people tended to own back then. So there are a lot of these baby boomers moving into that age group. Okay, some risk and protective factors. So we've already mentioned the lifestyle. So the age part we've talked about. If there is a family history, again, that's what we want to pay close attention to that. There is a gene that can be tested and have a person surveyed and monitored very carefully. There's this new thing so for a long time in the field of medicine and health psychology, we have known about type 1 diabetes is when the pancreas fails and the person doesn't produce insulin and they have to do insulin injections. Type 2 diabetes was considered to be more of an interaction between a genetic predisposition and poor lifestyle over time. And so you're more likely to see type 2 diabetes in individuals who are very sedentary and don't exercise or get much physical activity, who do not eat very healthfully, who are morbidly obese, so very large in obesity. That's the type 2 diabetes. Type 3 diabetes is this new term that we're using in healthcare that's talking about the toll that poor circulation, poor like sedentary lifestyle, poor eating, all that kind of stuff, the damage that it has over time on the brain. And one way of thinking about type 2 and type 3 diabetes is individuals have very high levels of blood glucose floating through their circulatory system. And you all know that if you heat sugar, it liquidizes, but when sugar cools, it forms spiky crystalline, kind of like a lollipop type thing. So imagine having really high levels of blood glucose floating through the bloodstream that is sharp-like and can create damage. So there's both, almost like mechanical damage that can occur there. From a dietary standpoint, the best diet for brain health is what has been termed the rainbow diet. And the rainbow diet would be eating lots of fruits and vegetables and beans, legumes, that type of thing, lentils that are highly pigmented. So if you think about plant-based products, the more pigment, hence the rainbow, okay, the more pigment in those foods, the healthier those foods are for you. And then if you think in the fish market as an example, like salmon is very healthy in terms of the types of good fats that salmon has. And it tends to be, some trout is too, it tends to be that bright orange when the fish is raw, as an example, okay? And so the best diet for brain health is mainly plant-based with plant-based oils, and plant-based oils tend to be liquid at room temperature, as well as fish that has the good fat in it. But an attempt at avoidance or limiting other animal products where we eat cows, pork, and chicken. Okay, so the lower the animal products, the more the plant-based, the healthier. We know when it comes to alcohol use, abstinence from alcohol is a little less healthy on brain health than very moderate use of alcohol. But heavy use of alcohol is very dangerous on the brain. Okay, so some moderate use. We know that individuals who continue with mental activities later in life tend to have healthier brains. And one way to think about it is practice makes perfect. Okay. I've seen a lot of individuals, just as an example, decline upon retirement. And I've known a lot of individuals who go into retirement and then would come out of retirement or go into retirement, get a part-time job, start volunteering. The more that people are moving around, engaging with others, using their brain to do puzzles, to play games with other people, that type of thing, the better. Okay, so keeping the brain active. The NSAIDs are medications like baby aspirin that bring down inflammation. And we know that inflammation, particularly inflammation in the brain, is bad. That's going to spew out all kinds of mood issues, all kinds of cognitive issues. So using the NSAIDs to try to keep inflammation at bay. We know that individuals who have advanced education, mainly because people with advanced education, and you all have probably heard this term, and we certainly, one of our goals in higher ed is we want to create for you all lifelong learners. Okay. And part of what you learn in undergrad is how to learn. Right. And then for a lot of you, it's why many of you were going to make career shifts, and move into areas that you might not have thought you moved into because you know how to learn. And employers love that because your college students are easily trainable. They're usually thirsty for knowledge. They're thirsty to gain new skills. So that advanced education makes a lot of sense because advanced education oftentimes leads to a lot of those mental activities, as well as a sense of meaningful life. We know that people who are bilingual, and it's certainly easier to learn a second or a third language when we are much younger and our Chomsky center in the brain is thirsty for language. It's a little bit harder, like most of us attempted to do, learning a second language in high school or in college. But it makes some sense. A bilingual brain is more sophisticated in their ability and how they use language. And then last but not least here, I am a huge fan of exercise for physical and mental health. I prescribe exercise on a regular basis for my clients. A well-nourished brain is more likely to be a nice, healthy brain, and it's going to age more slowly across time. So any questions here about any of the risk factors, protective factors? So a lot more lifestyle involvement than what scientists first thought. Okay, I'm going to stop my share. So we're going to end early today, but what questions do you have about what we've talked about? Anybody?
I kind of missed what you said about moderate alcohol consumption.
Oh, okay.
Does that actually help or hurt?
It's protective. And we're usually talking about, like, say, a glass of wine a day, a glass of beer a day, when we're talking about moderate. Or 2 for guys, 1 for gals. And some of that has to do with the relaxation effect. Some of it could be a little bit of cardiovascular relaxation effect on the blood pressure. Some of that has to do with some of the chemicals found, particularly in red wine, as opposed to white wine. And then similarly, beer. But then also a lot of the cultures that tend to drink a lot of wine tend to eat a lot of plant-based foods too. So, yeah.
Okay, thank you.
Sure. Other questions, anybody? All right, well, you got 15 extra minutes to your day. Use it wisely. Maybe go exercise or buy some pigmented food. Good to see everyone. I'll see you on Thursday. Bye-bye.